Thank you for watching those videos for the examination. I'm trying to cover the examination of the board exam. So the examination today is a knee examination. So as usual, I have to find the doorway information that I have to read in order to approach the patient in the correct way. So I'll give a very quick hint regarding the examination. So most of the time, the examiner will not ask you to examine the whole system or the whole joint in the same time. So basically, they will ask you to examine part of the knee. For example, if it's a knee examination, he will ask you to examine for the anterior instability, posterior instability, for example. He would ask you, they can ask you also for the bulk of the muscle. So it's rarely being asked to examine the whole joint in the one session because it will take a time. So what I'm going to do, I'll do complete full knee examination. So you can pick up different parts of the examination every time you go for any exam. So first of all, we have to start the same way. Knock at the door. Greetings, Assalamu alaikum. My name is Dr.Aissam. I'm a Libyan board exam candidate. So would you mind if I examine your knee? No. Okay. So Mr. Muhammad, so if you don't mind, I just want exposure. I want you to take off your pants. I want to be, that you become in the underwears. And if you don't mind, I want you to remove your shoes. I'll just go and wash my hands first of all. So I'll start my examination at the patient. So the patient is sitting comfortably on the trolley. He doesn't have any walking aids. I can't see any obvious deformities. He doesn't look in pain and he doesn't look distressed. So Mr. Muhammad, do you have any problem standing or walking?
No.
Okay. First of all, just if you don't mind, I'll take your shoes. I'll examine the shoes. I'll see if the patient has any show wears inside for any lifting or any supports. Also, I have to see the wear patterns of the shoes, which is not available here. He has symmetrical wear patterns, which is normally for the knee. So, Mr. Muhammad, do you mind if you make a few steps for me? Okay, so try to kneel while the patient is moving down and come back to me. Okay, so the patient is ambulating steadily. He doesn't have any abnormal gait. Okay, Mr. Muhammad, can you please sit on the trolley? Okay, so while you're sitting in the trolley, I want you to extend your knee. Okay, so I want you to extend your knee, then flex it back. Let's start with the right side. Okay, flex it back, do the other side. So this part of the examination is quite important, looking for any particular mat tracking, so I can't see any J side of the. Please, could you lay down? Okay. One of the things that I can't do while the patient is standing or sitting is inspection, but I'll do the inspection while the patient is lying down now. So looking at the knees from the front, I can't see any scars, any deformities. I can't see any wasting. Both quadriceps abyss symmetrical. I have to look very close to the knees, looking for any arthroscopy scars, which are not available here. Also, looking at the knee from the sides, also they're quite symmetrical. Hamstring bulk are quite symmetrical. I can't see any scars, any deformities. There's no lumps. Looking from the knee from the outer side, could you please rotate your knee to the inside? Yes. Okay. Looking at the popliteus also, I can't see any scars, any deformities, no lumps. I have to do the same thing on the other side again. Both knees look symmetrical. I can't see any obvious deformity, wasting or scars. Again, I can do the inspection while the patient is standing or while laying down. So, do you have any place in your knee which hurts or painful?
No.
Okay. So, next I have to do feel or palpation. So in order to do that, make sure that your hands are warm, and I have to start very systematic. So I would start with the tibial tuberosity, looking at the patient's face, then going into the bis anserine, medial joint line, okay, medial side of the patella, lower border of the patella, upper border of the patella, lateral part of the patella, lateral joint line, fibular head, okay, going back, biceps femoris, popliteus fossa, and semimembranosus. So there's no painful point on the knee. Also, I don't have to forget to examine for any hotness. Okay. Then I have also to examine in case if I see or I can find out any wasting of the quadriceps, I have to examine for any quadriceps wasting. So the way to do that is making a clear line, which is the joint line, and measuring 10 to 15 centimeters approximately, and I have to make the tape measure around it. I have to repeat it on the other side also, and to compare how much difference is the quadriceps wasting or the muscle wasting. Okay, after I finish with the palpation, now I have to do one special test which is quite important before moving into the move part, which is the examination for any knee fusion. So in order to examine for a knee fusion, I have to evacuate the suprapatellar pouches in this way. Then I can do patellar tab, look at the patients. So in case you can do the patellar tab, so the knee fusion is moderate, the other way is to do a bulge test. So again, I have to evacuate the suprapatellar pouches, then I have to evacuate the medial parapatellar or lateral parapatellar and look for any bulge, which is the bulge test. Since I'm here around the patella, I prefer to finish patellar examinations, so in order not to forget them. So the patellar examination, one of them is the patellar, after the patellar tab, patellar tilt. I have to take the patella laterally and I have to tilt it, feeling how much the patella goes laterally in order to subluxate. I have to ask the patient also to flex his knee at this point. Could you flex your knee? And looking for any patellar apprehension, which is negative. Okay, you can do the patellar tilt, patellar also grind. So it's not advisable, especially in older patients, to do the patellar grind test, which is a test for patellar chondromalacia or patellar osteoarthritis, because it's painful. But you can do the grind test gently and look at the patient face in case he's uncomfortable, so you know that the patient has patellofemoral disease. So the way to do the patellar grind test is press on the patella and grind it around the trochlear fossa. Okay. After that, I would ask the patient to do an SLR. Could you lift the whole leg up? Okay, so the patient is able to do SLR. That means maintained extensor mechanism. Could you please bend your knee to the maximum? Okay, so the patient is having range of motion from 0 to 140 or 150 degrees, apparently. Also, in case that the patient doesn't go beyond 100 or 110. So at that point, I have to help the patient passively to get to more flexion. So at that point, I can say that the patient is flexing passively to 150 while actively to 100. There are 2 points in the exam that you need to be very much aware about it, which is the either fixed flexion deformity or extension lag. For the fixed flexion deformity, it's the deformity where the patient cannot really flex, cannot really extend his knee beyond certain degrees, most of the time 30 degrees. So at that point, try to extend the knee passively. If it doesn't extend passively as well, so this is fixed flexion deformity. But if it extends passively, so this is extension lag. So there are 2 different conditions. So extension lags occur where there are some extensor mechanism problems or failure of the quadriceps tendon or patellar tendon, while the fixed flexion deformity is a pure intra-articular problem where the joint either stiff or the ligaments inside are quite stiff. So I'm done with the movement, so now I have to go into the special test. In order to arrange yourself for the special test, you have really to be systematic. So we're done with the patella, so because it's the most forgotten part. So now I have to start, my way is to start from the outer side to the inner side. So for the outer side, I would examine for the collaterals first of all. The way to do that, you need to examine the collaterals while the patient with extension 0 and at 30 degrees. So in extension, if the patient gets into varus or valgus, that means the collateral and the ACL or BCL is injured. If the patient has any laxity on 30 degrees, so this is isolated collateral issues. So first of all, the way to do that, hold the knee still, and in order to do the valgus stress test, I do it while making some force, valgus, at 0, and at 30 degrees. While the varus stress test, there are different ways of doing it, but the way that I like, I keep my hand in this position, I do varus at 0 and at 30 degrees. So the patient has grade 1 varus stress positive, which is less than 5 millimeters. Okay, and he doesn't open in a valgus stress test. I'm done now with the collaterals. I have to go more inner part, and I have to do the examination for the menisci. So the examination of the menisci, it's McMurray's test. The way to do that, keep your hand on the patient's foot, heel, and put your hands on the joint line, okay? The examinations of the collaterals. So remember it's a contralateral. So in order to examine, it's a distraction force, not a compression force. To examine for the medial collateral ligament, I have to take the leg in external rotation and on a valgus force, and I have to go from flexion to extension and look at the patient's face. Okay? And in order to examine for the lateral collateral ligament, I keep my hand on the joint line and I do internal rotation of the foot and a varus force and going from flexion to extension. And this is for the lateral collateral ligament, and it's negative in this patient. Then I have to go for the ACL examinations. For the ACL examination, one of the tests is the Lachman test. So the patient size and my hand size are quite easy to do it. So you hold the hand, you hold the thigh with one hand and the leg in the other hand. Look at the patient face and see for any translation. Okay. Of course, this kind of examination you need all the time to compare it to the other side and look at the translation of the tibia or the femur. The other test for the anterior cruciate ligament is the anterior drawer test. So for the anterior drawer test, since you flex the knee, you have first of all to examine and look for any sagging. So put your hand at the back of the heel bilaterally. Look at the legs from the side, look for any posterior sag. In case of there's any posterior sag, that signifies posterior cruciate ligament injury. So if the patient has any sagging, press on the feet and ask the patient to extend the legs. Could you extend the legs? So if the sagging corrects, this is a positive quadriceps active test, which signifies posterior cruciate ligament injuries. Also at this point, you can do also anterior drawer, both hands on the posterior part of the thigh, both thumbs on the joint line, look at the patient face, do anterior drawer this way, and then you can do the posterior drawer in this way. Since the patient is keeping his legs flexed or knees flexed, now you can also examine for the posterolateral and the posteromedial instability. For the posterolateral and posteromedial, it's not like the meniscus, it's a ipsilateral. So for the posterolateral instability, I have to do a foot external rotation and I have to do a posterolateral drawer, which is negative. For the posteromedial instability, I have to do anterior internal rotation of the foot and I have to do anterior translation, not a posterior translation. Okay? So now I've finished the examination for the ACL, BCL, and posteromedial, posterolateral corners. There are certain special tests that you need to take the permission from the examiner in order to do them. One of them is the pivot shifting test, which is for the ACL. The way to do the pivot shifting, you put your hand in the patient's heel, apply a valgus force, internal rotation, and take the knee from extension to flexion and look for any gliding or clicking while the patient is going from extension to flexion, and this signifies pivot shift positive, which is anterior cruciate ligament injuries. The reverse pivot shifting, which is a test that we're doing for the posterolateral corner instability. So again, it's a valgus force, it's external rotation, valgus force, and going from extension, flexion to extension. And look for clunk or any gliding of the tibia over the femur. So The pivot shift and reverse pivot shift is taking the tibia from a dislocated position into relocation position. So we are actually reducing the tibia back whenever we're doing any kind of those tests. Other tests that we need to do before shifting the patient into prone position is external rotation recurvatum test. This signifies also BCL injuries. I hold both big toes of the patients and extending the knee in this way. So if the knee become recurvatum, this means the BCL is injured, which is not here. Okay, now we're done with examination in the supine position. Now I ask the patient to go back into prone position, if you don't mind. Two important tests that you need to do while the patient is in prone position. One of them is a dial test. So the dial test is you look for the external, you external rotate both knees while they are 90 and in 30 degrees. I look for any difference between the external rotation of both legs, of both feet. If any difference more than 10 degrees of external rotation, this signifies an injury. If the difference is more while the patient is in 90 degrees, that means PCL and posterolateral corners are injured. If the external rotation difference is more while the patient is in 30 degrees, this signifies, while the patient is in 60 degrees, this signifies isolated posterolateral corner injuries. You can relax this one. So, and the last test that we need to do is applique compression and distraction test. You have also to take the permission of your examiner before doing this exam. Put your knee over the patient's hamstrings and do distraction with internal and external rotation. Look at the patient face if he's in pain, and do it again with compression. Any pain or discomfort signifies meniscal injuries. Mr. Mohammed, could you turn back, please? Yes. At the end of the examination, don't forget to thank the patient. Thank you very much for your time, and sorry if I caused any discomfort for you. Thank you.